thanks for inviting us to your clinic here in Bangkok today. Really appreciate you joining us.
Thank you very much for coming.
Thank you very much.
I know that you flew from Malaysia just for this interview, so we're very appreciative.
Actually, we flew from all over the world. We
Flew from everywhere.
Yeah.
We connect
But
everywhere.
we're ready to meet you anyway.
Yeah. Well, thank you so much.
It's a
So,
great pleasure for us.
really interested to get your perspective on cancer and the treatments that you're doing for cancer. Before we started, you started going through a litany of different treatments and protocols that you're using for cancer and testing and so forth. So if you could, to begin with, share a little bit with the audience. You can go first, Dr. Mike.
No, you can go first.
Okay, Dr. Dmytro, you go first about who you are, a little bit about your education, and then that'll get us going, and then we'll get into the treatments.
I done my medical degree and graduated from Ukraine. It was almost 20 years ago. And so far I worked for two governments. The first government I was working in Ukraine in a government hospital. I was working in the university. I've done my PhD in surgery. That was in the year 2006. And I was treating all patients, the general surgical patients, including the cancer patients, you know, the abdominal forms of cancer and soft tissue, and so on. And then 10 years ago I moved to Asia because of the family reasons and other things, you know. And I was working for Malaysian government as well, in a conventional hospital, a government hospital, and treating probably thousands of cancer patients and 10,000 patients overall. You know, so my approach to cancer treatment, definitely the roots are from the conventional medicine. So in terms of the diagnosis, for example, I do not and never neglected the general principles, you know, in the guidelines, how you're supposed to diagnose it, because it's very important. And to be honest with you, I think that the modern medicine is advanced very much in terms of how they can diagnose. So we can diagnose better than ever before, definitely better than 10, 20, 30 years ago. Even certain forms of cancer have been discovered, for example, for the past 20, 30 years, which we didn't know, we were not aware of them before. For example, the neuroendocrine tumors, and we have the specific markers for the neuroendocrine tumors, for the gastrointestinal tumors. This was all not known in the 1970s. But the outcomes, unfortunately, they are not really, they can't keep up with the pace of how we can diagnose it. And also, if you compare the outcomes of the cancer treatment for the past 25, 30 years, I believe basically we're just at the same place. You know, the percentage of the survivors, you know, and the percentage of people who don't make it is basically the same. There were a few quite, I would say, shocking things that I've encountered during my practice in conventional medicine. For example, one of them was in the year 2012-2013 when I won the grant from the Japanese Society of Hepatopancreatibiliary Surgeons. And I was invited for the annual meeting, the conference. I went there and I did the presentation there. It was in May, June 2013. Okay, and there were researchers and doctors, practitioners from all over the world. There were people from the Mayo Hospital, you know, from the Rochester and things like that. And when they were presenting their results, and for example in treatment of liver cancer, no offense, but it looked like they're like 20 years behind what the Japanese were doing. You know, and certain things that I heard from the stage from the Japanese presenters, they said like already since 10 years ago, 5 years ago, we know that certain types of chemotherapy, for example, S1, which at that time we didn't know in Malaysia, you know, we didn't know in other countries in Southeast Asia, nobody knew about the S1 therapy. You know, we still were using the gemcitabine, the capecitabine, and things like that for the pancreatic cancer, for example, for the cholangiocarcinoma. And in Japan, they say, oh, we know since mid-2000s that the S1 is superior to these things, you know, and I talked after that to my oncologists in Malaysia, and they say, oh yeah, we heard about it, but we don't have it, you know. So it was quite a shocking and disappointing to find out that a lot of countries, they're actually behind in cancer treatment, you know, and there are some countries like Japan, for example, or Germany, which are much more advanced because they're much more daring. You know, they, the way how they approve new medications and new approaches to cancer treatment are much faster and more efficient than in some other countries, you know, which are considered to be developed, you know, and we can see it on the international conferences, you know. So
talk about Dr. Mike was mentioning earlier that you're developing or producing B17 in Germany.
Well, the B17 in Germany, it was never banned. You know, it was part of daily practice. You know, you can say
all the physicians are using
all the physicians are using this. You know, this partially because of the legislation, partially because According to the constitution in Germany, the doctor and the patient, they have more freedom to choose what kind of therapy they're going for. So as long as it is proven that it's not harmful for the person, and the B17 had actually 2 clinical trials which are done a long time ago in 1960s. And from what I was reading about it, it actually showed the positive outcomes. And then certain things I can't explain, like why, for example, it was banned and disapproved in certain countries, probably as far as I know in the United States, when there were actually good results of the trials. So it's like you suppose that, you expect that people gonna use it, but it's gonna be banned, after that. These things I can't explain. I don't know why it's happening. So things like the hypothermia, for example, things like certain ozone therapies. Even Spain is doing that for the tumors which are for the NPC, the nasopharyngeal carcinoma. I've seen it with my own eyes. There was one of the presenters, he was from Spain, the professor, and all. They've done the study together with the ENT surgeons when they were injecting directly the bicarb with the local anesthetic and ozonated concoction right into the tumor, and the tumor was shrinking, and quite fast over the months. And then after 3-4 months of the therapy, you see that actually it's a scar tissue there. Nobody can tell whether you have cured person from cancer or not, because only the time will show that. You will know after a few years whether there's a recurrence or not. But you can see that the tumor is shrinking, and that was done on multiple cases.
And what was that treatment again?
That was they were making a special concoction which is made out of, mostly it was the ozonated alkaline solution, which the cancers, they are more prone to the acidic environment. Okay, so when you change the microenvironment in the tumor to the alkaline state, it causes something like a regression of the tumor. And with the repeated procedures, which are minimally invasive, it's not an extensive surgery. And they actually managed to achieve the reduction of the tumor volume. And shrink after that. So B17 is one of the points, is one of the aspects of the therapy. So as I said, the hypothermia, the ozone therapy, the GCMF, which is immunomodulator, it was studied from Japan. They're still using it in Japan, and I mean, nobody is harmed for that, nobody is banned, and the people are using it.
Right, it's hard to get GCMF in the US now.
Yeah, it's
We are the first producer of GCMF in the world.
I'm
The
sorry?
first producer of GCMF in the world. It started in 2011.
You are the first producer.
We are the
of
one of the first,
Okay.
because the original, the Japanese, they're producing it, it's produced from the donated blood. So I do believe that might have some issues maybe in Europe and all, with the legislation that blood is not for sale and the blood products and so on. But the GCMF that we're producing in Australia is not made of the human blood. It's more like the enriched bovine colostrum, so no animals are harmed. You can say that it's a biological product.
Can you explain a little bit about what GCMF is?
Yeah, it stands for the macrophage activating factor. So we have the monocytes, which are the cells, immune cells that are circulating in our blood. And basically, monocytes are not the active cells. They need to change, to convert themselves into an activated cell, which is called a macrophage. And usually that is happening in various conditions. First of all, there has to be the antigen, any foreign body, and then the monocyte has to be activated. So there is this macrophage activating factor that, unfortunately, in certain conditions, like in a cancer patients, for example, or in a certain viral infections or bacterial infections, they produce certain biological substances that will suppress the function of this and the production of the macrophage activating factor, intrinsic, endogenous. So as a result, the monocytes are not converted to macrophages. So they cannot perform phagocytosis. So one of the lines of the immune response is impaired.
And what is phagocytosis?
The phagocytosis is the process when the immune cell is engulfing and digesting the antibody, whether it's a cancer cell or whether it's a bacterial cell, any antigen, any foreign body. Okay, so it's one of the important aspects of our immune protection, right? So when it's impaired, definitely the tumors have a chance to grow faster, and to metastasize and things like that. So it was discovered in 1990s in Japan, all right? And they found it out first. It was in a group of the breast cancer patients, advanced forms of the breast cancer patients, when they found out that they have a certain enzyme elevated, okay? And when they try to explore what exactly is that enzyme doing. They found out that that enzyme is actually inhibiting and blocking the macrophage activating factor. That was the idea, how they found out how it works, and then when they artificially administered that to the patient, they've seen that the enzyme is dropping. It's like a tumor marker. It's there's a certain level of the normal range, but in pathological condition it shoots up. So when you do the therapy with the GCMF, you see that the tumor marker is dropping dramatically.
What's the name of the enzyme?
It's in short they call it nagalase. It's alpha-1 acetylgalactominidase. So
that's impressive. You knew the whole thing. But nagalase, right?
Yeah.
Okay. Because I thought it was nagalase. I've heard of nagalase before.
In short, they call it nagalase.
Okay.
And then the transfer factors. It was actually first was found out and discovered by one American immunologist. It was in late 1960s.
And the Russians did a lot of research on transfer factors.
On that, yeah, but the problem that actually happened, there were a few unfortunate events, like there were the interleukins and interferons, which I found out just 2 years after that, and the study that was initially done was not really clean, so there were some adverse effects, and some of the patients were infected, accidentally.
With transfer factor?
Yeah, when the studies were done on the transfer factor in 1960s, and it was about 69, 70s.
Yeah, because I remember reading they had kind of a bad rap for a while.
But it's a fantastic thing, because it's something that has the properties of the antibodies, and it's like it has the immunological memory. It's antigen specific, but in the same time, it also has a function of it boosts so-called the innate immune system in a form which is in our systems represented by the natural killer cells. So that's a fantastic type of immune system because it's not the adaptive immune system. We don't have to encounter the antigen. We're born with that. Genetically, we already have that form of the immune system in the form of the natural killer cells. It's fantastic, It's a ruthless assassin killer of cancer cells, Unfortunately, it is very vulnerable as well, So with the transfer factor therapy, and it's safe, it's not toxic. It's basically no side effects, no adverse reactions. You can't overdose it, And in the long run, it also has an immunomodulatory effect. It's not only boost the immune response, it mostly improve your cellular immune response. But if, say, some patients have an overexcited humoral immunity, like the autoimmune disorders and all, it will sort of normalize and stabilize the immune system, It's fantastic. The Thymus therapy. Germans have studied Thymus therapy a long time ago, probably
some 200 years ago.
Yeah, in the 90s, 40s already, they had actually the commercially produced products and all, and they've used in the live cells with the thymus cells and all. The thymus it's a gland, in our chest, basically, that our bone marrow is producing immune cells, but they are not matured, all right? It's immunologically, you can call them Th1. It's like immune cell, which is ready-made, but it's not trained what exactly it should do. It's not grown up yet, it's just like a baby. So it has to reside in thymus, and it has to mature in thymus, and it will obtain certain properties as either T lymphocyte, which is a helper, or killer, and so on. Final differentiation, it's happening there. Unfortunately, we lose our thymic tissue as we age. 25 years and above, it's shrinking. We're talking about a 50-year-old individual, a healthy individual. It has about 15-20% of the thymic tissue left, and all the rest is just fibrotic tissue mostly. So it means that the T line of our immunity also is declining, it's impaired. And it's an unavoidable physiological process, So when you modulate the function of the thymic, of the thymus, you can actually improve the T line of your immune system.
And is this oral therapy or is it intravenous?
Well, it's not really oral. It's injectable. You have to administer that. But in the old days, it was used as a live cell. They were actually implanting into the patients an actual thymic cells, the thymus cells, which in a way is used even now. Even for certain patients, we can do it even now. But then the research which we had from 1970s and 80s shows that it's not even always necessary to use the actual cells of the thymus, because you can do it with the thymus cell extract. So the peptides, they actually will modulate the function of your thymus, the remaining thymus. They will sort of boost it, improve it. So in this case, you can go away just with the extract cell.
And does that act as not only anti-aging but also anti-cancer?
Oh yes. Put it like this: we're talking about immune system. Of course, in many cases, we know that when the patient has cancer, they have the suppressed immunity. It's what is primary, what is secondary. It depends on the case. There are some forms of cancer which appear because of the suppressed immunity, and there are some forms of cancer which actually cause the secondary immunosuppression. But in any ways, if you improve the natural immune response, definitely you improve the outcomes. And another thing that we have to look into is this way. I'm not against chemotherapy or radiotherapy or surgery or something radically, definitely not. Because I myself am a product of a conventional medicine. But I believe that the truth is somewhere in the middle. You cannot just disregard one side, and completely fall into the other side. It's somewhere in between. Certain forms of cancer, they do require chemotherapy, and there are so many forms of chemotherapy, chemotherapeutic drugs, which are more toxic, less toxic, and more targeted, less targeted, But it is a fact that immunotherapy and radiotherapy, they do have a side effect, adverse reaction, immunosuppression. So if you treat the patient with this approach, definitely it's almost guaranteed that you will have more or less immunosuppression after that. And you increase the chances of septic complications, bacterial complications, fulminant sepsis. I've seen patients with my own eyes when they were sent for the chemotherapy consented with the oncologist and all. And after the first cycle of the chemo, within a week, 5 days, even 4 days, patients, some of them develop fulminant sepsis, and they pass away, within a week. No matter what you do, any ICU support cannot help them. So it's all because of the immunosuppression. So if with our immunotherapy we can at least reduce or get rid of those adverse effects, and reduce the risk of septic complications and so on, that is fantastic, And the recent study shows that if you use immunotherapy concurrently, parallel to some conventional methods, you actually improve the outcome, sometimes by double, the survival of the patient. That is just great, that's our target.
Thank you for sharing all of those different, you're hitting cancer from a whole bunch of different angles.
Absolutely.
It sounds like it's most of it focused on immunotherapy.
Directly and indirectly. For example, in the case of GCMF, you can say that this is immunotherapy, but once you activate monocytes, they become activated macrophages and all, they will effectively attack tumor tissue. They will consume basically and digest, the tumor cells. So it means that with this therapy, you are directly trying to affect the tumor load. You're trying to reduce the tumor load. When you do other types of immunotherapy, for example, with the STF and all, you just increase the immune response of the patient. Probably you reduce the chances of metastasizing and things like that. If you're talking about the systemic hypothermia, it's a fact, the biological fact that the tumor cells, cancerous cells, they don't like heat, they don't like high temperature. They will be the first to die. On top of that, a session of systemic hypothermia, it produces a huge amount of endorphins and catecholamines and all, and also the cytokines, the chemokines, which in their turn, they will affect tumor tissue. One session of systemic hypothermia gives you a tremendous pain relief. I've done it myself. I'm like a recreational athlete, so I have sometimes a muscle pain, and things like that. When I do a session of systemic hypothermia, I'm like a newborn next day, When I wake up next morning, I have no aches, no pain. I have tremendous energy, So imagine a cancer patient, even with the advanced form, who's suffering from chronic pain, and fatigue and all. Imagine how the quality of life improves after this. It's not only about, I put it this way, some people we cannot help, unfortunately, when they develop certain disorder, eventually they will die. But for us as medical practitioners and as human beings, compassionate human beings, it does matter what is the quality of life and how people gonna live their life and how long they're gonna live. Whether they're gonna suffer for 3-4 months in a hospice or in a general ward or going through the chemotherapy, or they're gonna live twice, thrice, or 4 times longer with a tremendously different, better quality of life. You just think of the person as a human being, of the family members. Isn't it the goal, you know? I think it's quite a noble goal, you know, for the doctor.
It is. It absolutely is. Dr. Mike was sharing the same thing before,
Yes.
about you should do whatever you can to give the person quality of life, whatever's best for the patient.
Absolutely.
So I appreciate you saying that. Dr. Mike, you were sharing something before about the stem cells and the
Yes,
importance of that.
to compliment Dr. Dmytro, I sincerely think you need the stem cells here, because you have to understand, to tackle cancer, you have cancer stem cells. So you must also use the stem cells to tackle cancer stem cells. They're so strong. Okay, so basically we have to understand in general, there's a lot of difference and misconception with stem cells. Okay, for example, when we are born, we have 37.2 trillions of cells, and 744 millions are the stem cells. That means the proportion is 1 stem cells out of 10,000 live cells. But by the time of age of 18, we only have 30% left of our stem cells in the body. And by the age of 30, you only have 25%. By the age of 60, we have around 5% left of our stem cells. Just view stem cells just like a queen bee and the mother queen bee and the rest of the bees. So the queen bee will be having all the best nutrients, right? So the same situation here. We all understand that cancer, like all disease, will be a compromise of the system in the body. The system is comprising of the 200 organs and tissues in the body. And what is inside the organs and the tissue? The cells. The cells age like the organs, and we are aging like our biological age and never the chronological age. That means if I'm 57 today, which I am, my cells, my organs inside on different organs will have different lifespan. For example, the brain starts to age at 20. The fertility of a male and female start to age at 35. The eyes of a physician will start to age at 50. The gut in us will age at 55. So there is a lot of compromisation here. So if we can extend the lifespans of the organs, that means you have to expand through the cells. The quality of the cells determine the health of the organs and tissue. So for these reasons, you must use feeder cells. When we talk about feeder cells, they are cells which have gone through organogenesis. That means there's a one-way ticket, it's no more return. They will not turn back to embryonic cells. So it's good to use the feeder cells, is because in the feeder stage, cells of all animals, including human, sitting on top of the animal kingdoms, they are alike. It is only in the feeder stage that when you inject feeder cells into the body of any patients, which have been done for thousands and thousands of patients, including patients as young as 6 weeks old Down syndrome children, okay, there isn't any complication of what everyone was talking, anaphylactic shock or things like that. It have never happened before in my history of 32 years in this line. We are manufacturers. We are people who do the research in the lab. My other partner, my wife, Professor Michelle, is also engaged with me. We spent 32 years of our life in Switzerland and Germany and Europe, and even in many parts of Europe, where we've been doing all this with the lab research, and then with the production. And 10 years ago, we started to acquire a number of clinics in Switzerland and Germany. Today, we own around 3 clinics in Germany and Switzerland, and around 7 clinics in Asia. In the next 6 months, will be another addition of 5 clinics across the world, adding to the 15 and more is coming. And all these clinics are involved in the field of biological medicine, integrative, and regenerative medicine. So stem cells, being one of the top things in regenerative medicine, is very much needed. But again, like I said, there was a lot of misconception about stem cells. Stem cells doesn't mean it will treat all kinds of disease. It depends on what kind of disease. For autoimmune, I think you have to complement with other therapies like ASI therapy. We call it active specific immunotherapy. Now, coming back to cancer, like what Dr. D was mentioning, there was a modality of treatments. To complement with all these other treatments, you do need the stem cells. Because if you use the stem cells, it'll be the best cells. Okay? So if you use stem cells of the thymus, or stem cells of the transfer factors, or stem cells of others, it works better. So normally for cancer patient, okay, we will complement with the bone marrow. precursor stem cells of the bone marrow, we use the spleen, we use the mesenchyme, of course we use the thymus too. But if that patient is a liver cancer, then we have to give the stem cells of the hepatocyte. And we have to understand in the liver, yes, we have to understand in the liver there could be around 80 cell types found in the liver. The liver is a filter, but it's also a dustbin of cells. All the cells will be found there. So we have to, in our case, we have to do a series of culturing process which involves 11 to 14 days in the lab to isolate the hepatocyte from the rest of the liver cells. You know, we have to take out the hepatocyte. We don't need the rest of the cells to be injected into the patient. So this determines the quality of the cells. At the end of the day, it's a quality. You know, you have a car, what is the car purpose of car? Transportation, okay? And you need to reach to a destination, certain destination, you need a car. But you have to understand, you have a Tata car which will cost you $800 US, but you also have a Lamborghini which will cost you $2 million probably, okay? So why must you have a Lamborghini then? Because you need to reach a destination maybe at a faster speed. So the same things go for the cancer. If the cancer patients need to be treated, let's say in the case of pancreatic cancer or liver cancer, only for a few months to live, let's say for 3 months to live, okay? You must use the stem cells in this case to super boost the immune system together with the rest of the other therapies, because the immune system are compromised so much, okay? So what we do is, we must use the stem cells, and we cannot use just any other cells, because it will not work that way it is, because they take a longer time to reach there. So in this case, you cannot even use the peptides. Use the stem cells, but complements with the peptide, and today with our technology for the last 16 years, we have managed to create all these injectables into oral supplements by way of sublingual. The pores of human is around 50 to 75 nanometers. We have created to 2 nanometers. So they are so small that they can go through the mucosa of the tongue, which is part of the digestive tract, and they go straight into the bloodstream, just like an injection. So this is what we do with all the patients. It's not just of cancer, but all kinds of therapies. There's a lot of difference between live cells and stem cells. Please understand that. To me, the stem cell, the precursor stem cell will be the 6-star. The live cell will be the 5-star. Because in our production, everything comes back to the manufacturing in the lab. Because in the lab is where the manufacturers will decide the quality. It's like this cup, let's say this is a cup of coffee. This could be 1 cup. I can mix 60 cups into 1 cup by making it very concentrated. Okay, but I can also make this 1 cup become 8,000 cups by diluting it. Okay, so in other words, the quality of the products can be diluted, and that's where the price quality will be compromised. Because in the process of selling at a cheaper price, some manufacturers will go down with the quality. But on our side, our policy is to add quality life to the ears of the patient. So we always insist there must be a quality. To us, it must be a Rolls Royce and a Lamborghini to give the treatments to the patient. But at the same time, we also have to think of some other ways to save for the patient, you know, because not everyone can afford the patients. We have been writing a lot of books and research, okay. We are one of the first people who contribute to stem cells research books in 2006, and we are still continuing writing a book this year, 2018. There's a book on stem cells. Yes, and one will be on biological medicine, and our team, Dr. D and I and the rest of our medical team has been doing a lot on the research side. I'll be passing a lot of all this to you and some of the books too. So we continue to do what we have to do. Yes, we are under pressure from different parts of the world. Okay, it's like I was hearing from you, GC-MAP is not easily available in US. It's true, but in certain parts of the world it's widely sold. Even in Japan, it's widely sold. Okay, but again, in anything, there's always scams coming in. You know, everyone can say this is GC-MAP, but it may not be. It's just like transfer factors. It's just like B17. Okay, B17 injectables must be refrigerated, and most of the time, some of the physicians who buy the B17 is not refrigerated. Okay, and we have been manufacturing B17 for many years in Germany. It's not just a B17. There are so many other therapies which have been. The good thing about Germany and Switzerland and other parts of Europe is all these are coming under the branding of individualized therapy, where the physicians are treating the patients individually according to the individualized condition of the patient. So the cells and the concoction or modality of treatments are approved because it was only for the treatment of that patient. So we don't have a problem with treatments of cells in this case, or cell therapy we call it, because you prepare the cells according to the condition of the patient. So every physician have a license to produce in the manufacturing facilities in Germany or in our lab. You know, we are having one of the best lab in the world in this. Okay, but it's not just a preparation of the peptides of the cells. We also do the stem cells. Okay, now again the stem cell, we have the autologous stem cells. Okay, and out of the autologous stem cells, we also have to understand the cells are as old as a biological age. So I'm 57. The cells from me will not be very young cells. Then I rather took the allogenic cells from my kids, which are younger. But again, you have to understand in the human body, the problem is when you take the cells, you can only take the mesenchymal cells from autologous. There's not many other cells you can take from, okay? But mesenchymal cells is only one of the precursor cells out of the 220 cells in our body. So if you were to treat someone with a muscular degeneration, okay, ocular degeneration, you need the optic nerve, you need the retinal cells. There's no way you can use mesenchymal cells to do that. Neither can mesenchymal cells be a cardiomyocytes or hepatocyte. And what about the 40 different types of brain cells in our body? Okay, and you cannot take the mesenchymal cells to be a pineal gland or to be a medulla alba or a brain stem. Now, for this reason, it must always be A to A, B for B, C for C. What I'm trying to say is
targeted.
You must be targeted, organ-specific targeted. That means to say you must always use a A type of cells to only take to treat the A, and B for B, and not just A for A, B, C, D. Okay, so that was the situation where physicians have to understand they cannot use just autologous mesenchymal cells to treat certain disorder.
Do you have the equipment in here in the lab that you here in this office?
Not here, but in our lab we do have it.
We don't have them.
But we do have some. You see, in the treatments of all these patients, okay, you must have the clinic because you need the guidance, experience of the clinicians. But at the same time, then you have the therapy. Then you have the follow-up, which will be a take-home. So it goes along the way, and then the physician and the clinic have to monitor the patients. It's like a diabetic patient. You bring down the sugar level. Okay, you can bring down the sugar level, but the guy will continue to eat with his lifestyle, and then the sugar level will go up again. Okay, so we have to monitor them at all the time.
Hey, thank you so much for sharing, Dr. Mike, Dr. Dmytro. Awesome.
Thank you very much.
Appreciate it.
Yes.
Yeah.
Thank you.